Oh, okay. Prenatal diabetic screening, high risk patient, obesity plus one of the following prior GDM or prior macrosomic infant. If yes, first trimester screen. If abnormal, then GDM. If high risk patient, no, third trimester screening. Abnormal, GDM. Normal, no GDM. If there is GDM, then screen. Postpartum screen. If it is normal, 1 to 3 hours of glucose screen and first trimester screen. If it is abnormal, then type 2 diabetes mellitus. Gestational diabetes mellitus is common in associated with obstetric complications, stillbirth shoulder dystocia, preeclampsia. Therefore, all pregnant patients require GDM screening with a 1 hour glucose challenge test that is usually performed in 1 hour glucose challenge test that is usually performed in 24 to 28 weeks of gestation when maternal insulin resistance increases physiologically due to placental release of diabetogenic hormone. However, early screening for undiagnosed pre-gestational diabetes mellitus (GCT) at initial prenatal visit is indicated for high-risk patients with obesity plus one of the following prior GDM, prior macrosomic infant birth weight more than 4 kg, prior history of type 2 diabetes mellitus, first degree relative polycystic ovarian syndrome are suggested by patient's irregular anovulated menstrual cycle and maternal age more than 40. Identifying undiagnosed pre-gestational diabetes mellitus during delivery can help optimize glucose control and decrease the risk of pregnancy complication. Even if the early screen test is normal, a repeat 1 hour GCT is performed at 24 to 28 weeks of gestation. Is this arrest, second stage of arrest? Uh, because 4 hours, 4 or more hours in primary and 3 or more hours. So second stage of arrest. So, it is in between C and D, isn't it? Okay. Vacuum assisted. Okay. The second stage of labor. Uh, the second stage of labor is the period from complete cervical dilatation 10 centimeter to delivery. This patient achieved excellent fetal descent to plus 3 due to her average sized infant 3.4 kg, suitable pelvis, no fetal molding or caput, suggesting no resistance against the bony maternal pelvis, and favorable fetal position left post occiput anterior. However, she meets the criteria for second stage arrest. However, she meets the criteria of second stage arrest and no further fetal descent, which are 3 or more hours pushing in primary cavity epidural, without an epidural, and some providers allow additional time with epidural, 4 or more hours pushing with an epidural, as in this patient, or 2 or more hours of pushing in multigravida without an epidural, and 3 or more hours of pushing with an epidural. Continued pushing increases delivery complications. Okay. Continued pushing increases delivery complications, postpartum hemorrhage with limited chance of spontaneous delivery. Therefore, the best next step in the management is operative vaginal delivery, vacuum assisted, to expedite delivery. Other indications for operative vaginal delivery include maternal exhaustion, fetal distress, and maternal condition in which Valsalva maneuver is not recommended. Valsalva maneuver is not recommended. Hypertrophic cardiomyopathy. I don't understand how hypertrophic cardiomyopathy. Why hypertrophic cardiomyopathy is recommended, is not recommended in HOCM. So how it is related? Okay. Yes. Internal podalic aversion is a manual rotation of an infant to a breech presentation for breech vaginal delivery. Internal podalic version of a singleton fetus is contraindicated because breech vaginal delivery has a high risk of neonatal mortality and morbidity. Then the internal podalic version is done for whom? For, sorry, internal podalic version is of a singleton fetus is contraindicated. If there is a duplet or triplet, then we do internal podalic version. Okay, then D. Okay, the ideal fetal head position is occiput anterior. Ideal fetal head position is occiput anterior because the flexed head presents with a because the flexed head presents a smaller diameter and facilitates the cardinal movement of labor. In contrast, the occiput posterior position presents a larger diameter of the head in a deflex position. Rotate the fetal head of occiput posterior, decrease the chance for spontaneous vaginal delivery. Sorry. Okay. It's cutting. I can. Yes. Yes. I'm following you now. Okay. Yes. It's better now. You have downloaded Discord in the laptop. Okay. Okay. We can try it at the last moment. For because uh, today I faced some of problem in the Skype. Like it's okay. Maybe as it is going to in the end days, so it's getting problematic. Yes. Is it normal, dilutional, or like that? Looks like, or maybe or maybe thrombocytopenia in pregnancy. Okay. Okay, if we go through this box, gestational is isolated mild, gestational isolated mild, asymptomatic, and a diagnosis of exclusion. Preeclampsia with severe features or HELLP syndrome, there may be hemolysis, elevated liver enzyme, low platelet. So there is moderate to severe, less than 1 lakh, less, and hypertension with or without scotoma, uh, with increased creatinine and increased AST and ALT. ITP, isolated, moderate to severe, also less than 1 lakh, asymptomatic or moderate, or asymptomatic or mucosal bleeding, bruising. normal PTA-PTT, and TTP, thrombotic thrombocytopenic purpura, severe, less than 30,000, neurologic symptoms, confusion, seizures, fever, abdominal pain, petechiae, normal PT and APTT. And for DIC, moderate to severe, less than 1 lakh, PT, APTT high, there is bleeding with or without thrombosis. This patient most likely has gestational thrombocytopenia, a benign condition that causes an isolated mild thrombocytopenia platelet 1 lakh to 15,000. Gestational thrombocytopenia occurs 5 to 10% of the pregnancy and is likely due to physiologic increase in plasma volume during pregnancy dilutional effect. It is commonly diagnosed in the third trimester on a routine complete blood count as in this patient, but can arise as early as the first trimester. Patients are asymptomatic, no bruising, bleeding, or anemia, and have normal physiologic symptoms of pregnancy, such as in this patient fatigue, shortness of breath, symmetric leg swelling. Patients with isolated mild thrombocytopenia in pregnancy are assumed to have gestational thrombocytopenia. Because of this condition does not because this condition does not affect obstetric or neonatal outcomes, and because are platelet counts usually normalize within 6 weeks of delivery. Self-limited management includes reassurance and observation. In contrast, symptomatic or moderate to severe thrombocytopenia less than 1 lakh require evaluation for an alternate diagnosis, TTP. Okay. Okay. Exercise is encouraged is normal, but uncomplicated uncomplicated pregnancy to maintain overall fitness and well-being. Exercise is also associated with decreased risk of excessive gestational weight gain and gestational diabetes mellitus, as well as faster recovery from vaginal and cesarean delivery. However, the recommended types of exercise and the ideal frequency or duration of exercise differ from pregnant patients. During pregnancy, certain type of high risk exercise are avoided. Activities that place patient at risk for abdominal trauma or falling. Examples of activity that should be discontinued include contact sports, horseback riding, and downhill skiing, as in this patient, and certain activities, hot yoga, that increase the risk of for dehydration, a common cause of preterm contraction, and decrease placental perfusion. In contrast, this patient may be advised to continue jogging because jogging carries a low risk for falling and acute dehydration, switching to low impact activities only. Swimming, walking is not strictly necessary. Switching to low impact activities only. Walking, decreasing frequency and the duration of the exercise is not duration of the exercise in this patient is also unnecessary, because guidelines are recommended 20 to 30 minutes of moderate intensity exercise able to engage in normal conversation during activity on most of the days of the week. Okay. Weight is low, below third percentile. Look at the weight. Circumference 50 and length is um, there is only her mom. She has chronic hypertension. Yes, tell be constitutional or chromosomal. So, hypertension, uteroplacental insufficiency regarding to hypertension, isn't it? Birth less than. Is it in this graph? What does it means? Like in the weight, is it birth weight or is it the which one? Birth weight is less than third percentile or estimated fetal weight is less than 10%. Which one we should? Both is down. Both are down to. In the weight, look at the weight. Uh, According to this graph, it is below third percentile. Like birth weight is below third percentile for gestational age, isn't it? And in the graph, they have told us about the gestational age. Oh, sorry, gestational age and the birth weight. Maybe it's means birth weight, not the fetal estimated fetal weight. Okay, okay. That's confused. Okay. So fetal growth restriction is characterized by estimated fetal weight less than 10 percentile or birth weight less than third percentile for gestational age. Neonates who are small for gestational age, neonates who are small for gestational age, birth weight less than 10 percentile are considered as growth restricted. detected if maternal risk factor for poor fetal growth, maternal hypertension, preeclampsia are present. Fetal growth restriction is characterized by symmetric, in which all growth parameters are small, and asymmetric, in which weight is low, head circumference is normal. Weight is low, head circumference is normal. Whereas symmetric fetal growth restriction is typically due to an insult in the early in the pregnancy, genetic condition, congenital infection. Asymmetric fetal growth restriction commonly caused by decreased blood flow and oxygen delivery to the fetus, uteroplacental insufficiency in the second or third trimester. Asymmetric fetal growth restriction is head sparing because neonatal delivery is preferentially redistributed to essential organs, brain, heart. The most likely cause of uteroplacental insufficiency in this case is maternal chronic hypertension. Management of newborns with fetal growth restriction include prevention and treatment associated with complications such as hypoglycemia, polycythemia, hypothermia, and poor feeding. Catch-up growth is typically achieved by age 2, but long-term growth, neurodevelopmental abnormality can occur. Okay, yes. Constitutional small for gestational age is a variant of normal growth in which neonate is small in length and weight due to genetics small parents. In contrast, the patient has asymmetric growth parameters, head sparing, and the risk factor for placental insufficiency, maternal chronic hypertension, making pathologic growth restriction fetal growth restriction more likely. Inaccurate pregnancy dating can make all growth parameters appear falsely low related to presumed gestational age. However, the best sonographic estimate of gestational age is a first trimester crown rump length measurement, which this patient had. Crown rump, which this patient had. Where is that? This okay. Therefore, inaccurate dating does not explain the low birth weight or asymmetric parameters seen in this unit. Uh, how this crown rump length measured, I do not know. Okay, maybe. Okay, crown rump length. It measures of an embryo or fetus from crown means head and rump means the buttock. From head to buttock measurement, head to buttock length is measured at roughly 6 to 13 weeks. Why accurate gestational age is crucial for monitoring fetal growth and development and assessing the risk of chromosomal abnormality, planning for prenatal testing and estimated EDT and estimating. It is usually measured using ultrasound imaging. Okay. That one. So in ultrasound first trimester, like in the dating scan, what we call, like when at that time crown trump length is measured. Okay, now I got the point. Okay. evolution for female Evolution for female factor infertility often includes hysterosalpingography to identify the genital tract anomaly and fallopian tube patency. These patients hysterosalpingogram reveals two unfused uterine horns, finding consistent with either a bicornuate or a septate uterus, which are types of congenital uterine anomalies. Those with uterine anomalies have distorted uterine cavities can lead to adverse reproductive and obstetric outcomes, including the following: spontaneous abortion, spontaneous abortion, congenital uterine anomalies are commonly associated with absent or abnormal vasculature and diminished uterine blood flow. Therefore, pregnancies experience decreased placental perfusion and inadequate nutrition, which can cause fetal growth restriction or recurrent pregnancy loss. And preterm labor, because it has two separate small uterine cavities. A bicornuate, it has two separate small uterine cavities. A bicornuate or septate uterus cannot expand fully in volume to accommodate a full-term pregnancy. When the fetus become larger than the cavity, uterine overdistension may trigger preterm labor. Uterine anomalies may also adversely affect the structural integrity of the cervix, increasing the risk for cervical insufficiency and second trimester pregnancy loss. Some congenital uterine anomalies, such as septate uterus, can be surgically corrected to recreate a single large uterine cavity for improved obstetric outcomes. Okay. Yes, 12 weeks. The urine pregnancy test is positive. He has a history. Look at the history. Cervical conization. This patient has a history of cervical intraepithelial neoplasia. This patient has a history of cervical intraepithelial neoplasia 3, uh, CAN3, and subsequently underwent cold knife conization. CKC, a cervical excision procedure for treatment. For treatment 8 months ago, cervical excision procedure. Lip CKC excised the entirely transformation zone surrounding areas of endocervical canal. Although these procedures are highly effective cervical dysplasia treatment, they have clinically significant late developing sequelae, particularly CKC, which allow greater depth and access the endocervical canal. Specific pregnancy complication including the following occur because a removal of the dysplastic tissue also excises a normal cervical stroma. Cervical glands loss of cervical stroma is thought to reduce the tensile strength and the cervical plasticity, which can result in either second trimester pregnancy loss or preterm birth. Loss of cervical glands reduces cervical mucus barrier to infection, which increases the susceptibility to ascending infection and increase the risk for pre-labor rupture of the membrane. Because infection is a trigger for rupture membrane. Pregnant patients with a history of CKC may undergo cervical length measurement to evaluate their risk for preterm birth. Okay, and it is not like fetal growth restriction. Where is this option? Okay, B. A maternal risk factor for fetal growth restriction include malnutrition, hypertension, and vascular disease. None of seen is okay. Next. Is it like hernia, uh, non-tender abdominal mass protrudes between the rectus and is it ventral hernia after or rectus sheath hematoma or hernia? Okay. Okay, okay. Okay, observation. Rectus diastasis. Okay. So this patient has rectus abdominis diastasis due to weakening of the linea alba, the fascia that lies within the rectus abdominis muscle. The fascia then lies the rectus abdominis muscle and keeps them in close proximity. Risk factor for rectus abdominis diastasis include chronic abdominal stretching, pregnancy, multiparity, surgical weakening, prior cesarean delivery, and increase in abdominal pressure, constipation, all of which weaken the linea alba. As the linea alba weakens, abdominal contents bulge between the rectus abdominis muscle, especially with the valsalva, resulting in non-tender midline mass. Unlike a true hernia, rectus abdominis diastasis has no associated fascial defect, and patients have no associated pain, acute GI symptoms, and risk of bowel strangulation, incarceration. Therefore, patients are managed conservatively with observation and reassurance. Rectus abdominis diastasis resolves post rectus abdominis diastasis typically resolves postpartum. Surgery is typically reserved for cosmetic reasons in those whose diastasis does not resolve. Diastasis. Sorry. Yes. Abdominal binders place external compression of the abdomen and may cause fetal growth restriction. Therefore, they are not recommended in pregnancy. Growth restriction. Okay. Very important. MRI can be used to identify unclear anterior wall defect. MRI can be used to identify unclear anterior wall defect and associated structure. The diagnosis of rectus abdominis diastasis typically can typically be made clinically. Yes, it is post-dural because it is positional. Okay, this postpartum patient postpartum patient with a severe headache after recent epidural anesthesia most likely has a post-dural puncture headache. This during placement of neuroaxial anesthesia, unintentional or dural puncture may occur, causing CSF fluid low cerebrospinal pressure, low cerebrospinal fluid pressure, resulting slight herniation of the brain and brainstem. Therefore, patients can develop positional headache. Headache worsens when sitting or standing, improves when lying down, which correlates with the increased and decreased hemoglobin pressure, increased or decreased herniation or pressure of the brain within 72 hours of the procedure. Other symptoms may include nausea, vomiting, neck stiffness. Most postural headaches are self-limited, and however, patients with severe symptoms that interferes with the activities and can be treated with epidural blood patch. Epidural blood patch. Yes, BPPV, benign paroxysmal positional vertigo, presents with positional nausea and vomiting and occasionally headache, but this patient has no dizziness, making this diagnosis unlikely. Is it history of ovarian cyst? It's torsion. Okay. In non-pregnant women, acute lower abdominal pain can have various causes involving the GI, gynecologic, or urologic system due to proximity of their structure. Many of these causes have classic presenting symptoms that characterize the disease process and differentiate the diagnosis. These patients' right lower quadrant pain is classic for ovarian torsion, which occurs due to rotation of the ovary around the infundibulopelvic ligament, causing ovarian vessel occlusion. However, although ovarian torsion can occur in the reproductive age, women those with a history of ovarian cyst, hemorrhagic cysts, or masses, mature cystic teratoma are at increased risk because the greater size and density of the ovary make it prone to rotation and subsequent torsion. Patients initially have intermittent pain associated with activity. As in this patient, due to partial ovarian torsion, the pain resolves the adnexia uh, when the adnexia spontaneously untwists and blood flow returns. When this progress to complete ovarian torsion, patient typically develops sudden onset severe non-radiating pain due to persistent ischemia, often associated with nausea and vomiting. Ovarian torsion can be diagnosed clinically Uh, but a Doppler ultrasound is usually performed to evaluate ovarian blood flow and confirm diagnosis. Treatment is with surgical detorsion to prevent ovarian necrosis, and cystectomy and nephrectomy may be required. Okay, okay, okay.